can I invite the panelists, Dr. Paolo Ghia, Dr. Pagel, Dr. Anil Aribandi, Dr. Padmaja, Dr. Subramanian. And first, I thank AstraZeneca for providing us an opportunity to discuss with leading experts in CLL. The questions are very simple. I mean, there is nothing very extraordinary about any of these questions. The first question is essentially a treatment-naive patient who walks into us, who's otherwise fit and well, can have any of the other three mutations which implicates a high-risk disease. This is a treatment-naive patient, young and fit, who has a high-risk mutation, either a 17p deletion or a unmutated IGHV or a deletion 11q. My question to the panelist is, the Indian hematologist particularly, is what makes you to decide on a particular type of treatment, whether it's a chemoimmunotherapy or the newer BTK inhibitors or BCL2 inhibitors? In fact, I mean, Dr. Ghia has clearly said that if you have a high-risk mutations, don't think of any chemoimmunotherapy. I'm really sorry that we are still short of any of these BTK inhibitors, and we have a good proportion of people who actually may not be able to afford any of the newer BTK inhibitors or the BCL2 inhibitors. Questions to first one to Padmaja or Dr. Deepesh or to Anil or Samal, anybody. Maybe we will start with Dr. Padmaja. What's your choice of therapy for these patients? A young, treatment-naive, fit patients who has one of the high-risk disease, and what would you be a choice?
Undoubtedly, if you've got a young patient and a high-risk disease, you would go for a BTK inhibitors, especially if you've got a 17p deletion. There is, I think the cost is previously, a couple of months ago, there was quite a bit of a concern with the finances. Now, with the generics come in, I don't find in real life that it is a huge difficulty, because even if you use a chemoimmunotherapy, they're going to be equally expensive or even higher. But of course, this is a longer term, and it works out for them with a high-risk disease. So I don't think for them, for this particular type of high-risk disease, cost is a concern at the moment who are affording a rituximab. So I would certainly go for that. And 17p is commonly we do for all the patients, but the rest of the mutations, mainly the IGHV mutation, is something we have to start doing it, which we're not doing it regularly. But 17p, yes, of course we do it, yeah. In this patient, my choice would be a BTK inhibitor.
Right.
Ibrutinib is a.
Hello? Dr. Prashanth or Dr. Anil Aribandi or
Subhash. Hi. Basically, young patient with any 17p deletion, obviously we go with the BTK inhibitor. But someone who doesn't have BTK inhibitor, the choice is whether you want to give chemoimmunotherapy like bendamustine and rituximab, which is very common in Indian setting. Usually, I use Ibrutinib in the second line, someone who has relapsed or someone who is an elderly patient with comorbid conditions, and someone who has 17p deletion. These are the patients I use Ibrutinib with rituximab combination.
Right. Our biggest problem is always about Ibrutinib is the indefinite treatment. I will come to that in a minute. But you have still a choice of FCR chemotherapy, which is a finite chemotherapy. None of you prefer FCR still?
So Dr. Priyanka here. For a young fit patient who has a very good cytogenetics without any of these prognostic markers, then we could think about an FCR. But having a deletion 17p or an unmutated IGHV, we wouldn't prefer for an FCR, which is a toxic regimen, and the cost is also high because of the supportive therapy.
Right. And Dr. Anil Aribandi, what do you think about FCR chemotherapy in P53 mutations?
I mean, if someone has TP53 mutations, FCR doesn't work. basically for these mutations, I think in UK we used to use what is that drug? Alemtuzumab, but here in India now Ibrutinib BTK inhibitor is better drug. Therefore, I think FCR has no role in. It doesn't give better results with someone who has TP53 mutations. And I mean, most of the people say that fit patients we can go for FCR, but what I have seen is practical in clinical practice. Most of us we have been using BR as first line. Someone who doesn't have.
So, Dr. Chezian, can I comment? This is Dr. Deepesh from PG. So as I completely agree with Dr. Aribandi that FCR is a regimen that is not very commonly used in India, predominantly because a lot of these patients have come from very far off places and supportive care for infections is not very good. So even at our center, if you look at our published data, the use of BR is more than FCR. And if you look at even the real world data with FCR, the benefit that was seen with FCR in clinical trials was lost in real world data. So recently, the Connect CLL registry from the US published their real world data from 200 centers. And they've shown that BR was as efficacious as FCR in terms of PFS benefit. So we are not wrong when we use BR specifically in patients who are mutated CLL. For patients who are unmutated or deletion 17p, naturally you would prefer to use Ibrutinib, but that again depends on the affordability of the patient.
And the second question is, are you going to use single agent Ibrutinib or are you going to add rituximab to it?
So the trial showed no benefit of adding rituximab to Ibrutinib. So I would use a single agent Ibrutinib.
All right. Okay. My question to Dr. Pagel and Dr. Ghia, and is it your choice of, we haven't got acalabrutinib, so I'm sorry, we haven't got a choice of starting on acalabrutinib. This patient comes into your clinic, you have a 17p deletion and young fit patients. What's your choice there?
Well, Paolo, I'll jump in. I'll let you maybe, I'll answer for both of us. I'll answer for both of us because I'm pretty confident we have the same answer. We really don't see a role at all for any chemoimmunotherapy of any sort in someone who has a 17p deletion and or a TP53 aberration. Those people do very poorly with chemoimmunotherapy. They may have a bit of a response, but it's very short duration, and the data is very clear that BTK inhibitors, and in your case, Ibrutinib, is an important advance for those patients. Or alternatively, it could be venetoclax-based regimen for those patients. Those are both reasonable alternatives, but chemotherapy in that patient population is probably the one clear place where we would say we should avoid chemoimmunotherapy.
Yes, indeed, I cannot, if not confirm what John said, meaning that if you have to use some money, that's where you would put it. And I remember some colleagues from northern countries in Europe that were saying, in case you don't have that, the only option is to use FCR and then go straight to an allo transplant, because you will know that even if they respond, it will last shortly. But some patients will not respond. I remember when I was young, some patient progressing under FCR. So that was really scary. So I think that for that population, novel therapies are, we say, mandatory, unfortunately.
The follow-up question is, how long do you think this, how long does the PFS last and how many people escape Ibrutinib? I have a couple of patients who are on them. They are older patients, but they escape within a couple of years. For these young and fit patients, if you're going to give them a progression-free survival of maybe a few years, that's still not enough, is it not?
That's a very good point. And of course, that's where one of the major unmet needs are for us in younger people. We do see people diagnosed at, 40, 45, 50 years old, and we want them to live another 30 or 40 years or so. That's a challenge. And I will say that we are making advances there. I will say that that's a patient population where I do have a conversation with them about the idea of being on therapy for long periods of time, but recognizing that we actually need to, think about the best way to be treating these people so that they do have the potential for that long-term survival. That's a major challenge for us. And I would argue that in some of those young, fit patients, if you had a 45-year-old patient who's well and, does not have high-risk features, there's still potentially a very major role for chemoimmunotherapy there, even though it's not the party line in the United States. And I would say the pendulum will swing back towards the center for those kinds of patients. Paolo, how do you feel about that?
I have to say that I'm not so, probably I'm in the middle between US and India, meaning that in Italy, indeed, we have Ibrutinib for all the P53 aberrant patients, but for all the rest, we have Ibrutinib only for the patient above 65 years of age with comorbidities. So for the young, the only option we have is FCR, indeed. Mm. And unfortunately, in my centers, we have clinical trials, so we always enroll them in clinical trials, so we always give access to novel molecules, but otherwise the standard would be FCR. With the idea, virtually, many cases, for example, unmutated cases, they do some FCR. If they don't respond so well, I hear from my colleagues that they just stop and then they move to Ibrutinib, second line, relapse refractory, so that's allowed for everyone. Of course, it's a pain when you cannot choose. You are obliged to use something because of the law and not because of the science. And it is also true that in young patients with a long expected PFS, but a continuous treatment, of course, that could be also somehow a burden for young patients who are not used to take pills and medicines, to think of taking that drug for 10 years. And I always say you should be thankful if you can take it for 10 years. It means that the response will last for 10 years. But it's also true that I believe and I expect that in the next few years, we will learn a little bit more about fixed duration, time-limited treatment. So I wouldn't be surprised if someone who starts now Ibrutinib in 2, 3, 4 years, we will know that maybe by adding one year of venetoclax or stopping even, there are even studies now with the discontinuation of Ibrutinib after a certain time, after a certain response. So we are really learning. I always say to my patients, don't even think too far because things are really changing monthly.
And just another question, how compared to Ibrutinib and Acalabrutinib, what's the chance of achieving a MRD negative disease with either of them? And if is it prudent to even check for it, or we just carry on with the hematological and the lymph nodal response?
Yeah, I'll give an answer to that. With single agent Ibrutinib or even single agent Acalabrutinib, the chance of becoming undetectable for MRD is almost zero. It doesn't happen with single agent BTK inhibitors. It is certainly true that the combinations, and Dr. Menon alluded to the Ibrutinib venetoclax combination as an example, can lead to undetectable MRD. Of course, venetoclax and obinutuzumab in the front line from the German CLL14 data as well can lead to undetectable MRD in about half of patients, but not with single agent Acalabrutinib. But remember, these are people often who are a bit older, who are getting treated. We're just palliating them. We're trying to keep their disease under control for a long time, hopefully do it well tolerated. I'm not sure that we have to become MRD undetectable in those people. Now, that might help us stop therapy at some point, and Paolo alluded to that coming hopefully in the near future. But right now, MRD assessments are really still an academic exercise as part of clinical trial, except for the one setting of using venetoclax-based therapy for time-limited treatment. Really, we know that if you don't achieve undetectable MRD by a year in the front line with venetoclax and obinutuzumab, you probably shouldn't stop treatment because you're going to relapse relatively quickly. So there perhaps is a role there, But even then, it's still an evolving, changing landscape. And I would say in the United States, even, we don't, outside of clinical trials, look for MRD detectability, even by more crude measures relatively, which are things like flow cytometry as an example.
The second question is nearly the same, but in probably a slightly older patient who had received bendamustine and rituximab as a first-line treatment, now has relapsed, predominantly with some lymph nodes. We have a habit of doing PET scans as a standard one for many of these patients now. Say there is an occasional high uptake PET with lesion, which worries you about Richter's transformation. So what's your choice of relapse treatment in these sort of people who have a bulky lymphadenopathy, has got a medullary as well as an extramedullary relapse? And what would be a choice of treatment?
So in this case, there is no Richter, there is no diffuse large B cell. This is so the
unfortunately, we haven't biopsied those ones. It's just on a PET scan.
The PET is probably around 5 or 6 SUV, or
it's around 5.5. Not a very florid uptake. I'm sorry.
So this is typical. That sounds like what is called accelerated CLL, which is CLL and should be treated as a CLL. And so this is the typical setting where BTK inhibitors are working fine. And let's remember that the major mechanism of action for BTK inhibitors is anti-proliferative action. So they're not inducing much of apoptosis, if not because the cells are displaced from the tissues into peripheral blood, but usually they really are anti-proliferative. So this is where they work nicely, where you see bulky lymph nodes and you can have a nice response. Again, since we are discussing so much about economical constraints, which are equal everywhere, and we have always to think also in an economical way, let's wait to treat the patient in the relapse refractory setting when they again meet the criteria for first-line treatment. So the lymph nodes must be bulky, above 10 centimeters. Patient has to be anemic below 10, be thrombocytopenic below 100 or below 50 now. It seems always the usual stuff, but that makes a difference in terms of month. And it makes a difference in terms also of cost, because it's less month that you have to pay your drug. And I remember a couple of patients who, as I said, Ibrutinib is allowed, this was first-line setting, of course, only if they were elderly above 65 years of age, and they were like missing 3 or 4 or 5 months to be in 65 years of age. And there you can really see that you can always wait a little bit longer with no risk of the patient. So I think the economical pressure in this case is somehow helping us to learn that we can always wait a little bit more without any harm.
Now, passing on to the pathologist, Dr. Subramanian, just a quick question. What's your, what test do? You do a peripheral blood flow cytometry or a bone marrow flow cytometry. What are the clinical, what risk stratification you can do to give it to the clinicians to make them decide more? So do you do a IGHV mutations? I know we all do a FISH now. I mean, a FISH is probably where we stand. But is there any role for cytogenetics, or do you do NGS or any sequencing to identify IGHV mutations, or just a P38 ZAP70 on the flow? What's all your risk stratifications which you give us when you actually have a patient who's newly diagnosed CLL or even at relapse?
Okay, am I audible? Yeah. At our center, we are generally, most of the patients currently, it's basically peripheral blood flow. They are doing marrow only if they are suspecting cytopenia. The FISH panel, standard routine of the 4 fishes for 11q, 13, 12, 13q, 12, and TP53 is done. So these are done as a routine, as well as many times at the time of diagnosis, we have to look at differential diagnosis of CLLs also. So IGH translocations are also looked for as a part of the standard work. So in addition to that, we are doing IGBH mutation, and now for the last 1.5 to 2 years, we are doing also the TP53 mutations by NGS, as well as NOTCH1SF3B1, the routine. So, but these are not very widely used in all patients. They are looking at based on the clinical requirement whether they want to know the information or not. So that's what we are doing. Though we have the capability for doing the minimal residual disease by flow, but generally it's not very clinically, necessary in the kind of treatments we use in our centers.
So, do you do NGS for P53 mutations? And
P53, yes, we do for TP53 NGS, as well as we are also participants in the ERIC CLL TP53 mutation EQA and stuff like that. So we are using NGS for that. So that we've been doing it. Only thing is, as you know, the option for going for Ibrutinib is limited in the number of patients in India. So generally, they clinically they do it only when they are looking for the option of giving an Ibrutinib to a patient.
All right. Quickly, Mohan, we have got really limited time, another 5 minutes, 6 minutes. And I'm sorry, the next slide. I'm just going to combine both the next slide and the other slide together. So basically, my question to the national experts on CLL, what stops you, what makes the patient stop using Ibrutinib? And that's one of the major problems in India. I will have a specific question afterwards, but what made your patient stop Ibrutinib? Which is the big one in India which makes them stop Ibrutinib?
Sorry, are you directing that to?
I'll just have a word from our Indian experts, and what specifically that stops people from using Ibrutinib, or the patients stop Ibrutinib.
So I can tell you about the experience at PGI. Okay. We have around 10 patients, roughly treatment naive, who are on Ibrutinib. It's relatively better tolerated in treatment naive patients than relapse refractory CLL patients. So I wouldn't say there have been any interruptions or any discontinuations as of now in our short follow-up in the treatment naive setting. But in the relapse refractory setting, we have around 30 patients right now, and it's led to discontinuations or even progression of disease or deaths in around 40% of patients. So definitely not well tolerated in the relapse refractory setting. We have seen a lot of infections in our patients. Infections like invasive aspergillosis, mucormycosis, even cryptococcosis. Okay. So yeah, these are some of the infections that we have seen in our relapse refractory CLL setting. So I would say the major advantage of Ibrutinib would be if it leads to better tolerance in the relapse refractory setting, and the usage will also depend upon what their launch price is going to be.
Okay. Right. And now that we have a generic one, I think people probably can afford more. And is that have any of you seen a significant bleeding? I have seen a couple of patients who actually slightly started a lower platelet count, actually bled a lot. And so I don't know. So a specific question before we move on to more. How many of us there is a significant problem in Indian patients that there is a significant lymphocyte spur when using Ibrutinib. In fact, many of my patients who started with a lymphocyte count of say 40, 50,000, as soon as they start to use Ibrutinib, it went to 70, 80,000. Doctor, you have given expensive medication, it's not working, it's all going up. And that's a particular problem which we have seen. And is it a particular problem elsewhere in Italy or US? And what do you do for those patients?
Well, it's expected, right? And it's really educating the patient to make sure that they know that that's what happens, that these lymphocytes come out of the marrow, come out of the lymph nodes and circulate in the peripheral blood for some period of time. And frankly, the last thing you want to do is stop therapy in those patients. So really, if they're doing well, they're feeling well, you can tell their lymph nodes are getting smaller, perhaps on physical exam. It's important to make sure that they know that this is exactly what we would expect and it's okay. And it may take many months before that lymphocyte count comes back to normal. And one of the things that we don't really understand, but it's important to know, is that it can actually, in some patients, take many, many months, even more than a year or so to come back to normal. And in some patients, small number, never comes back to normal. And the people that have those very slow resolutions of their lymphocyte counts are actually the most favorable patients for reasons that we don't understand. So even if it stays high for long periods of time and slowly is coming down, that's perfectly fine. And the patient should stay on therapy.
So do the B symptoms settle down in spite of having a high white cell count?
Absolutely. Yeah, go ahead, Paolo.
Oh, yes. If I may add just to say something, but really, I also always discuss during the watch and wait period with my patient, the lymphocytes don't count, meaning that we are not going to take any decision on lymphocyte. Patient will be treated because of anemia, thrombocytopenia, and lymph nodes. So the lymphocyte count is irrelevant for me and also for the patient before. So even after the BTK, it doesn't change much. And I always tell them, indeed, that we learn that the lymphocyte count is not relevant because we learn from the BTK inhibitors, meaning that we are spending 100,000 of euros to give a drug that increases the lymphocyte count, but decreases, of course, the size of the lymph node, increases hemoglobin and platelets. So this is what is really relevant. The lymphocyte count doesn't count. In fact, you have very good drugs that are effective and still the number goes up, but that does not correlate with B symptoms, does not correlate with any issue for the patient.
Just a last question on the side effects. Ibrutinib, over a period of few years, what's the major side effect we can expect? Say we have been using Ibrutinib for about a year or two now, but what happens in 3 years, 4 years, 5 years? Is there any particular side effect which we need to be worried in patients who particularly have been taking Ibrutinib for a long, long time?
That's a good question. We do have longer term follow-up data with Ibrutinib. Most people that have an adverse event that's significant with Ibrutinib, it usually happens in the first 6 months of treatment. Definitely pretty much within the first year, but most often, if you have a problem that's going to make you have to come off of therapy, it's going to happen usually in the first 6 months. There are two things that are potentially more emergent over time and a little bit perhaps atrial fibrillation, but mostly hypertension. So you need to watch for late hypertension, but otherwise the safety signal is consistent. You're not going to see something new show up at 5 years that wouldn't have shown up at 6 months or so, except potentially really for hypertension. So pay close attention to the blood pressure. Paolo, any thoughts?
Yeah, if I may add, what patient complains, because they usually don't complain about hypertension because they don't feel it unless you measure a score. But what they really complains with the longer follow-up under Ibrutinib is myalgia and arthralgia. This is also a mild thing that is definitely should not lead to discontinuation, but it's true that some patients can really complain a lot about it, and it's probably one of the few instances where we try to decrease the dosage, and then we, after a few weeks, we try to go back again, because this is something that, especially in the elderly, maybe they have pain for many other reasons, but it's something that they complain a bit. I would say if they don't have anything else, they would complain about that.
Yeah. Just two more quick questions. One to our pathologist. I'm really sorry. MRD. I know Dr. Ghia said that about, Professor Ghia said about MRD. Dr. Subramanian, what's your opinion on MRD in India?
Generally, MRD is used as a principle in all diseases where there is a chance of of the treatment, giving a good response that you want to know how much is the residual disease. So I think with the most of the chemo immunotherapy regimens, we have done maybe a very limited experience we would have done in say under 10 samples, and we hardly have got one sample in which there was a reduction in MRD beyond less than 1 in 10,000, but almost all the samples have not to the low level, but a significant burden of disease that you really don't require that kind of a sensitive technique with the regimens which we have. But with the future developments in treatments and future standard treatments becoming more and more available in India, I feel that the requirement for minimal residual disease will increase.
Dr. Pagel and Dr. Ghia, what's all the MRD which is available there? Do you do sequencings? Do you do just a flow? Or the biggest problem with CL is being there is residual lymphadenopathy as well. As it makes you wonder about minimal residual disease in the nodes or the sequencings or the FISH or the flow. What are all these? How do we classify MRD in CLL?
Starting from the point that at the moment there is no need to use assessment of MRD because indeed all the fixed duration treatment are fixed. So regardless the level of MRD, you have to stop.
Right.
So, and we cannot take any decision based on MRD. Unfortunately, though in the future it will be relevant, and as John mentioned, it should be included in all clinical trials, and actually clinical trials should be designed with MRD-driven endpoints. Having said that, what we think is MRD assessment will become very soon important. We, as Eric, we set up the standard for flow, which is I think is still the easiest, the fastest and quickest to have results. I have to say that I foresee that in the near future, couple of years, NGS will take over because it can go much deeper, and as soon as the prices come down, will be probably more standardized, and you can just it will be probably more reliable.
Right.
Dr. Subhash,
yeah.
I think we will be running. Can we restrict it?
Last question, sir. Last question. I will finish it here. The question to our international experts is: if you are going to use a finite treatment for any of these young fit patients who have got multiple decades ahead of them, what's your partner drugs? What are your partner drugs? Are you going to use a single agent? Or what a specific finite treatment for these young patients? Venetoclax, Ibrutinib, say Acalabrutinib, Obinutuzumab, Idelalisib. You take your choice. Is there any partners where we can use a fixed drug combination and forget about it for the next few years?
Well, I'll start. I'll just say likely for most people in the United States, that's a combination of venetoclax and obinutuzumab. We, of course, don't have an approval with ibrutinib and venetoclax, but we will soon. But even there, the data will actually not likely be better than venetoclax and obinutuzumab. And when you combine the ibrutinib and the venetoclax up front, you use it there, you might be burning a bridge for the ability to use one of these drugs later on. And we still don't know if combinations of therapy like ibrutinib and venetoclax are any better than just sequential use. And in fact, the data might suggest that progression-free survival is going to be longer with sequential use. So in a younger patient, I'm very attracted to venetoclax and obinutuzumab as a time-limited therapy.
Yeah. Right. How long do you think it needs to be done?
Yeah.
I'm sorry.
It's 1 year of treatment in the front line. It's 1 year of treatment. One difference is in the United States, we can continue with the therapy after a year. We don't have to stop. But in the majority of patients, you're going to be able to do that. And I think that's a very appealing approach for many patients.
Yeah. Is there any role for an allograft at the end of this?
No, sorry, I have to leave. It's my last answer. I have really to leave because I'm 15 minutes
late. I'm sorry.
Yeah.
Yes.
So I think that the issue, I fully agree with what John said. The issue here, and the major piece of information that we are missing is can we retreat the patient relapsing after Finite therapy with combinations with the same therapy or not? This is the key. If this is not possible, the patient will be resistant or will not respond as well as the first time, then probably they will have a limited use.
Right. Still a lot more questions asked, but paucity of time. Thank you.
For that, yeah.
Thank you.
Thank you all.